Sepsis remains one of the most pressing challenges in critical care, responsible for nearly 49 million cases and 13 million deaths worldwide each year. Beyond the acute mortality, survivors often face long term physical, cognitive, and psychological consequences. Hi, my name is Dr. Saf, and today we are going to be discussing Surviving Sepsis Campaign 2026 Guidelines, a landmark update in the management of sepsis and septic shock. Our session today will not only highlight the key updates but also focus on how these recommendations translate into bedside practices. Before we dive into recommendations themselves, it is important to understand how these guidelines were created because the strength of any guidelines lie in the rigor of its development. Guidelines were jointly sponsored by Society of Critical Care Medicine USA and European Society of Intensive Care Medicine. The process was fully funded by these professional societies, leaving no ground for any kind of bias from industry influence. A large international panel of 69 experts representing 23 countries was convened, representing diverse regions, specialties, and perspectives. They followed a structured methodology. So first they defined the scope of the guidelines and selected key PICO questions. Outcomes were prioritized based on clinical importance such as mortality, organ dysfunction, and quality of life. Evidence was systematically reviewed and graded using grade approach to assess the certainty of evidence. Then the recommendations were formulated through consensus voting, balancing benefits, risk, feasibility, and resource considerations. Importantly, the panel distinguished between strong recommendations where benefits clearly outweighs risk from conditional recommendations where evidence is lower or context matters, and then the third category of recommendations were good practice statements based on clinical consensus even when evidence was limited. So let's start with the first pillar of SSC 2026 guidelines, is screening and early management. A major update is the introduction of code sepsis or sepsis huddle protocols. A sepsis huddle is just in time multidisciplinary discussion at a patient's bedside to rapidly define and identify the sepsis and also to treat the suspected sepsis. Implementing a huddle can significantly increase the compliance with our one bundle, which was introduced in 2018, including faster antibiotic and fluid. So idea is to complete it very fast, and then documentation is also very important using the real-time EMR checklist. In the pre-hospital settings, ambulance teams are encouraged to use validated screening tools like PRECEPT score. So the PRECEPT score is to identify sepsis in the pre-hospital setting. But for in-hospital screening, the guidelines now recommend using NEWS2, MUSE is modified early warning score, or SIRS, systematic inflammatory response syndrome, rather than QSOFA. QSOFA is obsolete because as a single screening tool, QSOFA has not performed so well because of low sensitivity for early detection, and that's why it's outdated now. Importantly, the panel reiterates a good practice statement. Sepsis is a clinical diagnosis. It should never be ruled out or ruled in based on a single biomarker or test. So for example, if you perform CRP which is rising, you cannot say patient is developing sepsis until unless clinically you suspect with fever or tachycardia. Signs of SIRS should be also there apart from the laboratory investigation like lactate or CRP, WBC, procalcitonin, etc. So don't rely on a single test to detect or to screen the sepsis. Initial investigation. So initial investigation will be lactate measurement and the blood culture. Blood lactate measurement remains to be in the center of sepsis management. Elevated lactate indicates tissue hypoperfusion and helps guide resuscitation. But there is an important nuance in 2026 update. Clinicians are advised to individualize fluid therapy after the initial bolus of fluid and monitor lactate decrement rather than chasing complete normalization. Because if you try to normalize the lactate, you may end up over resuscitating the patient with the fluid, which may lead to fluid overload. And remember the U curve of fluid administration, where both under resuscitation and over resuscitation are harmful. So over resuscitation can be just as harmful as under resuscitation. Remember that always. So you have to, and this is the reason they say that after initial stabilization and when vasopressors are coming down, better to start evacuating the fluid. So SSC 2026 guidelines recommend that adults with sepsis induced hypoperfusion or septic shock receive an initial bolus of 30 ml per kg of intravenous crystalloids within the first 3 hours. The fluid therapy must be individualized. So what does that mean? That means that if the patient is having some kind of renal failure with the low urine output or cardiac dysfunction, then you can give little less fluid bolus. No need to give 30 ml full bolus. Okay, so that is your individualization based on the patient's host characteristics. We should calculate based on actual body weight or adjusted ideal body weight in patients with obesity. Okay, and reassess frequently to avoid both under or over resuscitation. So when it comes to fluid choice, there is no new recommendation in the new guidelines. They say crystalloids are the first line, and within crystalloids, balanced salt solutions are preferred over 0.9% saline, except in patients with traumatic brain injury where saline remains appropriate and better fluid. The guidelines advise against using starches or gelatins, as we know they are harmful given clear evidence of harm. Multiple trials are out there. Albumin is one of the colloid which can be considered in patients who have already received large volumes of crystalloid or in those with cirrhosis of liver, but should be avoided in traumatic brain injury. That is very clear. So don't give albumin in the traumatic brain injury. After initial fluid resuscitation, if hypotension persists, we move to the vasopressor support, the cornerstone of hemodynamic stabilization in septic shock. And now we have more data to suggest and to recommend that norepinephrine is the first line vasopressor, most effective agent for restoring MAP with the least arrhythmogenic potential. And regarding the target of MAP, they say 65 is fine, but if the patient is older, say more than 65 years old or older, a slightly lower range of MAP is acceptable, that is 60 to 65. So 60 to 65 millimeter of MAP target for older patient, and up to 65 millimeter of MAP target for other patients. Okay, remember, maintaining an exact number isn't practical actually, and that is what we were following in our intensive care practice. We titrate to keep MAP within a plus minus 5 millimeter of mercury window. If the norepinephrine requirement escalate, add vasopressin as a second line agent. When MAP remains inadequate despite norepinephrine plus vasopressin, then you can add epinephrine. In settings where vasopressin is not available, epinephrine can be combined directly with norepinephrine. For patients with cardiac dysfunction, either norepinephrine or epinephrine may be used as first line therapy. Choose based on breathing always. So norepinephrine for tachyarrhythmia and epinephrine for bradyarrhythmia. And we don't have enough data or evidence to recommend methylene blue. Finally, if hypoperfusion persists despite adequate fluids and MAP, add an inotropic support, usually dobutamine, to augment cardiac output, but always in addition to vasopressors, not instead of them. For adults with probable or definite sepsis or septic shock, antibiotics should be administered immediately, ideally within 1 hour of recognition. This is a strong recommendation supported by robust evidence linking early therapy to improved survival. For possible sepsis without shock, The panel advises a time-limited course of rapid investigation. If infection remains likely, start antimicrobial within 3 hours of suspicion. So you have some more time if the sepsis is just possible and there is no shock. Okay. Conversely, if likelihood of infection is low and there is no shock, defer antibiotics but continue close monitoring. This prevents unnecessary exposure and resistance. So, no need to start antibiotics in such cases where the likelihood of infection is very low. So in patients at high risk of MDR pathogens, use empiric antibiotics that covers these organisms. In low risk patients, avoid broad MDR coverage. Routine empiric antifungal therapy is discouraged unless there are clear risk factors such as immunosuppression, prolonged antibiotic use, or intra-abdominal infection. So no need to cover anaerobes until unless there are some risk factors, specific risk factors such as intra-abdominal infections, for example bowel perforation or intra-abdominal abscess, necrotizing soft tissue infection, empyemas, head and neck infection, CNS abscesses, deep obstetric or gynecological infections, and aspiration pneumonia. These are the important risk factors. Studies have not definitively shown that routine, broad, or unit-wide surveillance of upper respiratory tract translates into improved clinical outcomes. For example, reduced mortality or length of stay. While surveillance can detect colonization with multi-drug resistant organisms, it does not always predict the specific etiology of lower respiratory tract infections like VAP or upper airway flora often differs from lower airway infection sources. So this is very important to know that positive surveillance, like for example MRSA screening positive or C. diff screening positive, does not necessarily mean infection. It could be just a normal flora sometimes, so part of normal flora, or just a contamination. So no need to start antibiotics in such cases. For adults with sepsis or septic shock, rapid pathogen specific testing is suggested on a case by case basis. This conditional recommendation based on low certainty of evidence advises using rapid test along with conventional cultures to inform antibiotic stewardship. So it's good to use the rapid diagnostic test based on the PCR. Now regarding the Candida biomarkers to guide empiric antifungal therapy. The Candida biomarkers are not used in a vacuum. They are paired with clinical improvement like resolving fever, decreasing vasopressor requirements to confirm that the fungal threat has likely been ruled out or addressed. So biomarkers are like not recommended to initiate or stop the therapy. They are always paired with a clinical improvement or deterioration to start or stop antibiotics. Okay, so case by case basis. Now regarding the selective decontamination of digestive tract SDD in critically ill patients, obviously they have a role to prevent the infections. The topical paste, non-absorbable antibiotics like colistin, tobramycin and statin applied to mouth and throat, and there is some enteral suspension available, the same non-absorbable agent administered via nasogastric tube to decontaminate the stomach and gut, and there is systemic component also, which is a 4-day course of intravenous antibiotic, typically a third generation cephalosporin like cefatoxim. So all these antibiotics can be used as SDD, and the mechanism is that these eliminate potential pathogen from oropharynx and gut, lower the incidence of VAP and reduce the bacteremia. But evidence, and there is good evidence, especially in 2026 guidelines have been listed, that it reduces the risk of ICU acquired bacteremia and VAP. and there is some survival benefit also. There is a relative risk reduction of 9% in hospital mortality. So guidelines conditionally recommend STD still. Okay, it is these data are based on systematic review done by Hammond in 2022. Guidelines also reinforces antimicrobial stewardship principles, prefer prolonged infusion of beta-lactams after a loading dose, and use therapeutic drug monitoring when feasible. Conduct daily reassessment for de-escalation once cultures and susceptibilities are available. When source control is achieved, opt for shorter duration of therapy. Combine procalcitonin with clinical evaluation to guide discontinuation when uncertainty remains. Finally, the guidelines suggest that following adequate source control, clinicians should use procalcitonin and clinical evaluation to guide the therapy and to decide when to stop antimicrobials rather than relying on clinical evaluation alone. So, measuring procalcitonin periodically once patients have stabilized is very useful. And while procalcitonin is useful for stopping, the guidelines suggest using clinical evaluation alone over procalcitonin to decide whether to start antimicrobial therapy. So don't use PCT to start antimicrobial therapy, rather just use a clinical evaluation, SIRS, other inflammatory markers. Okay. As you know, antimicrobial therapy alone is not enough. If there is a focus of infection, it must be controlled. This is very, very important. And clinicians should rapidly evaluate for an anatomical source of infection, whether it is an abscess or obstructed biliary tract or necrotizing soft tissue infection or an intra-abdominal collection. Once identified, early source control, ideally within 6 hours, is recommended. So for identification of source control, you can do CT scan, you can do ultrasound abdomen, you can do even PET scan sometimes, and you can do other investigations like WBC scan, like nuclear scan also. Okay, so source control is very important, but it should be done within 6 hours after source identification. And there are multiple ways you can do the source control, like you can drain the abscess or empyema, you can debride the necrotizing tissue, you can perform surgical intervention for perforated viscous or obstructed bowel, you can remove device if there is device like PICC line or a catheter or DJ stent, etc. The panel stresses that delays in source control are directly linked to worse outcome. Even if antibiotics are started promptly, failure to remove the nidus of infection means ongoing sepsis physiology. Once resuscitation and vasopressor therapy are underway, continuous monitoring becomes our compass, guiding every subsequent decision. SSC 2026 guidelines emphasize that monitoring is not just about numbers, it is about trends, context, and integration. Next, dynamic measures should guide fluid therapy, not static parameters. Use tools like passive leg raising response, stroke volume variation, pulse pressure variation, or stroke volume change after a fluid bolus. These help determine the fluid responsiveness far better than CVP or IVC diameter or physical exam alone. So serial lactate measurements remain a key adjunct. Elevated lactate signals hyperperfusion, but goal is to monitor it and don't chase normalization of lactate. Combine lactate trends with clinical assessment like capillary refill time when used alongside of lactate and hemodynamic parameters provide quick non-invasive indicator of perfusion recovery. Sepsis and septic shock are not just clinical emergencies, they are system emergencies, and this is the reason guidelines emphasize that outcomes improve when both the patient and the hospital system responds rapidly and in the synchronization. So they should be in sync. For the patient, the recommendation is very clear: admit adults with sepsis or septic shock to the ICU within 6 hours of recognition. This ensures timely access to advanced monitoring, vasopressors infusion, lines, mechanical ventilation, source control interventions, etc. And they have shown that delay in ICU transfer can increase the mortality. But beyond the individual patient, the guidelines stress the importance of system approach. Hospitals should implement performance improvement programs. So performance improvement program was there also in the previous guideline, and in this guideline they have reinforced, reinstated dedicated sepsis improvement program and standard operating procedures for screening, resuscitation and escalation. So multidisciplinary teamwork, physicians, nurses, pharmacists, pre-hospital providers work together, and quality improvement strategies that track sepsis bundles, time to antibiotics and ICU admission metrics. All these system improvement or quality improvement strategies are very important because sepsis care is complex and time sensitive, and no single clinician can deliver optimal care alone. It requires coordinated approach with the administration. For adults with sepsis and acute hypoxemic respiratory failure who are not intubated, guidelines suggest a trial of awake proning, and this is, by the way, conditional recommendation and very low certainty of evidence. For adults with sepsis or septic shock, guidelines suggest against the use of antipyretic therapy. So they don't recommend antipyretic therapy, even they are against it, because sometimes it might mask the sepsis itself. This recommendation does not apply to using antipyretic therapy for pain control or for the patients who have other indications for temperature control, such as neurocritical care patients or patients after cardiac arrest. Okay, so it is okay for pain control, patient symptom control and other clinical indications. Once your acute resuscitation phase is over, initial stabilization has been achieved, then you should start fluid removal, active fluid removal, using either diuretics or the other methods, okay, like ultrafiltration, but diuretics is always preferred. A major shift in SSC 2026 guideline is moving beyond just surviving this acute phase to addressing the long-term recovery of sepsis survivors. These structured follow-up services are designed to combat post-intensive care syndrome, PICS, which can include physical weakness, cognitive impairment, and mental health challenges like PTSD or depression. So that's all for today. Thank you so much for your attention. I hope I have not taken much time, and I need your comment so that I can create more videos like this.